I'm Edward Capparelli, and I'm a family physician, and I've been very concerned about the problem of opioid overuse and misuse. Prior to the early 1990s, opioid medications were mainly confined to use in treating cancer patients or hospice patients. With the release of OxyContin in 1996 and aggressive marketing, synthetic opioids such as hydrocodone and oxycodone became increasingly utilized for acute and chronic non-cancer pain. Unfortunately, with more availability came more experimentation, and overdose deaths began to rise in the early 2000s. Federal recommendations and state laws limited the use of prescribed opioids in acute pain and high-dose use for chronic pain. Unfortunately, for moderate doses for chronic pain, no limits currently exist. We will take the next few minutes to explore opioid tapering for long-term or legacy chronic pain patients. I'm a family physician. I work with the Tennessee Primary Care Association. I've been working in Tennessee since mid-1993 in 3 different sites in East Tennessee, in Cott County, Morgan County, and currently Scott County. Since 2009, I have been the medical director at Mountain People's Health Councils based in Oneida in Scott County, Tennessee. I've been very involved in organized medicine, serving on the TennCare Pharmacy Advisory Committee since its inception in 2005, and currently I'm chairman since 2017. I'm also currently president-elect of the Tennessee Medical Association, and I'm actively involved with the Knoxville Area Drug Task Force, and I'm on the board of One Tennessee. For a 10-year period, I was the physician for 3 different county jails for Anderson County, Morgan County, and Scott County. I have seen firsthand the ill effects of opioids on individuals that were incarcerated. While serving on the United Healthcare Regional Peer Review Committee, I have seen physicians be sanctioned for poor prescribing patterns or inadequate documentation. All of these connections have given me greater respect and concern for the overuse of chronic opioids in treating non-cancer pain. I have no financial disclosures. The objectives of this talk are to discuss the scope of the opioid misuse problem, discuss which legacy patients should continue using prescribed opioids and which should have their prescriptions tapered, and finally, how to taper when that is appropriate. Drug overdose deaths in the United States have been gradually increasing despite the federal and state efforts previously mentioned. In 2019, there were 71,000 overdose deaths in the United States, with over 70% involving an opioid. In Tennessee, opioid overdoses increased 22% between 2019 and 2020, and many of those involved fentanyl. Since the beginning of the COVID pandemic, drug overdoses and overdose deaths have risen dramatically. Individuals don't start using heroin or fentanyl off the street as their first exposure to opioids. In a 2016 study from SAMHSA, almost 80% of the individuals who misused prescription pain medications had them either prescribed by a physician or received them from a friend or a relative. If you look at this graph, the dark blue and the dark tan colored are actual prescription medications that were gotten from the doctor himself or from a friend or relative. This has also been repeated in 2019, and it's almost exactly identical to what we saw in 2016. For every 100 patients receiving 4 pain pills a day, almost 150,000 pills are dispensed annually. If even a small percentage of these pills are diverted, that amounts to thousands of pills. Misuse starts at home. When we evaluate our patients concerning continuation of their opioids, we must weigh the benefits versus the risks. The benefits include pain relief, improved function, and improved quality of life. Risks include misuse or diversion, adverse effects like constipation and somnolence, addiction, and finally, overdose. Opioids should be considered when there is severe pain that cannot be managed by other means. Documentation of improved function or quality of life should be entered into your electronic medical record. Be reminded that not all pain responds to opioids. For example, opioids should not be used to treat headaches. Other concerns for prescribing opioids include advanced age or chronic conditions that may limit the capacity for a patient to properly metabolize opioids. Worsening mental illness or uncontrollable pain despite opioids are also warning signs. Finally, identification of alcohol or drug abuse should alert the provider that it is time to taper off and eliminate opioids. When opioids are prescribed chronically, it is important to do regular in-house drug screens. Although not required, I do them at every visit. Inconsistent results should be sent out for gas chromatography confirmation. The state-controlled substance database should also be checked at every visit, with queries to nearby neighboring states also reviewed regularly. Please note that since May 31st, chronic pain cannot be managed by telehealth. All patients taking chronic opioids should be educated in the use of naloxone and should receive a prescription to keep at home. Family members need to know where it is kept and how to use it. There are several red flags when using chronic opioids, such as wanting frequent dose increases or early refills, or inconsistent urine drug screens. Actual overdose or evidence of drug diversion are signs that opioids should be cut off immediately. It's much harder to assess lack of benefit. I've listed a few alternative diagnostic and treatment options when the opioids are no longer working effectively. If the opioids still are not helping, it must be remembered that not all chronic pain is opioid responsive, and that some pain may actually improve when opioids are tapered due to the paradoxical effect of hyperalgesia. Giving increasing doses of opioids may increase the adverse effects without improving the pain. When risks outweigh the benefits, it's time to taper the opioids. Urgency of tapering is based on the severity of the risks. I'd like to pause here for a second to remind everyone that we are not abandoning our patients when we stop their opioids. We are stopping the opioids to protect them, not to hurt them. As tapering is being considered, it is very important that you sit down and explain to your patient why you are tapering them and what alternative therapies you are considering. It takes much more time to stop the opioids than to just continue them, but we must always consider what is best for our patient. They will feel abandoned and often need to be helped throughout this very difficult time. Undiagnosed depression often worsens a patient's sensation of pain and needs to be explored and treated. Alternative therapies such as acupuncture and chiropractic therapy can also help. Here are some actual comments that I have received from patients when I have had to taper down their opioids. Can't you see I'm in pain? I can't live without my pain pills. I would never take anything you didn't prescribe. I don't know how it got in the urine. I thought you really cared about me. Well, if you won't prescribe them, then I'm just going to have to go and buy them off the street. The patient may become angry or tearful. In any case, the provider needs to remain calm and show concern, but resolve that this is what needs to happen. This is an opioid tapering strategy as presented from the Mayo Clinic. The take-home point is in the upper left-hand corner. With harm or risk, the taper should be rapid, whereas when there is a lack of benefit, the taper can be much slower. Some weaning protocols are presented here. Be aware that with diversion, the patient can be stopped immediately without any taper. If they aren't taking it, they don't need to be tapered off of it. A treatment option to consider when stopping opioids is buprenorphine for suspected addiction. That's commonly known as Suboxone. Some other options for withdrawal symptoms are also presented. Lofexidine is a very, very effective one. It's called Lucimira brand name. but it's also quite expensive. The combination of several generic medications can also be utilized. Now, many patients actually benefit from just lowering the dose. It's not always necessary to stop the opioid completely, and surprisingly, some patients actually report less pain when the opioid doses are lowered. In conclusion, it's important for providers to constantly be monitoring patients receiving chronic opioids. We need to be using all of the tools at our disposal to vigilantly watch our patients. When we feel that the risks outweigh the benefits, we need to talk frankly with our patients and always keep in mind that tapering down or taking off may be in the best interest of the patient. I will now open the floor for questions or discussion. I provided links here to myself and to One Tennessee if you would like to explore this topic in more depth. Thank you.
Dr. Capparelli, do you have any estimate about what percentage of patients have responded positively when you talk to them about opioid tapering, and how many have successfully been able to wean off, or is it most of them, half of them, or less than half?
Oh, it's much less than half. And are they happy? No, they're never happy, especially the legacy patients, because they have been on these medications sometimes for 20 or 30 years. And it takes time for them to understand the importance of tapering. I have had people get upset and yell and get angry. We have to have another option to provide them. Sometimes we've been able to get them off. It's not a very high percentage, but oftentimes they will just leave and try to go somewhere else and usually come back because they found that there aren't other people available. But as it's like we mentioned at some point, it's like getting the diabetic to stop eating his candy bars. It's a very difficult thing to do, but it can be done.
Hi, Dr. Capparelli. This is Sharon. Watching your slides, sort of remembered the importance of making sure that everyone reminds clients about the importance of locking up meds. I thought that was a great slide.
That is very important to keep control of them. I've had some people actually tie the bottle around their wrist when they sleep so that someone can't get to them. There are such things as Skittles parties and others where I've known of individuals in their late teens and early 20s that have actually died by taking all the pills they found in their parents' medicine cabinet, throwing them all together in a bowl, and taking a handful and seeing what that does. At any rate, yes, these are dangerous medications. There are take-back programs available for people that are no longer using them. We are prescribing much lower quantities for people that are seen in the emergency room or people that have dental or medical procedures done. But you're right, control needs to be maintained, whether it's with a lockbox or, as I said, tying them to your wrist, whatever you need to do. But we need to maintain control because, unfortunately, it's a very hot commodity. And much like smokers who have their children sneak cigarettes so they can try them out to see what they would do, we have the same problem with opioids. So we must maintain very strict control of opioids to prevent others from taking advantage of them. Are there any other questions?
So I do have one additional question. I'm thinking about the patients who you suspect to have a substance use disorder of some kind, and imagine that they're probably resistant to suggestions that they seek treatment or start that. How do you handle that? How do you get the patient to the recognition out of denial or refusal to admit, resistance to admit that they have substance use disorder and entering treatment if needed?
The good thing about community health centers is many of us have behavioral health programs integrated into our community health center. And we have, I have an addiction counselor, and I have a case manager, and I have a person that can do counseling. And in all three cases, what we can do is at the same time of their visit, when we talk with them, have them talk and get tied in with a counselor person. Usually a patient will deny that and will just go off and try to find someone else that will give them their opioids. But we can tie them into a program if it can be done at the same time and immediately. If it's a question of saying, okay, we can refer you out to someone that can get you in 2 weeks, that doesn't work terribly well.
And that is the end of this program. Thank you, Dr. Capparelli, for that important information, and thank you for taking the time to watch this One Tennessee program.